I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hi, everybody, and welcome back to another episode. Today we have with us Dr. Ira van der Steenstraten. Lovely to have you. Welcome.
Thank you so much, Sarah, for having me. It's really
Yes.
great.
And we're both in Australia, which makes our time zones for talking a little easier, but that's all right. Tell us about you.
Let me start with, as you can probably tell from my name and my accent, I wasn't born and raised in Australia. I'm from the Netherlands, and I did my medical training in Amsterdam quite a while ago. And in 2008, I came to Australia with my family, thinking it was going to be for a sabbatical of 1 year. By now, it's 18 years later, and we're still here in beautiful Brisbane.
I love that. I had a similar story. We were talking just before we got on the call about going to Canada for a year and ending up there for 12 years.
Yeah.
So, what brought you to Australia for a year? What did you come here to do and see?
I actually came for my husband's work. He was trained as an emergency physician, but it was a very new specialty in the Netherlands. So his last trainer, who was from Brisbane, he said, "Would you like to see what emergency medicine looks like 20 years ahead?" And we thought, why not? We had young children and it was perfect time. I thought I'll just pause my practice in Amsterdam and I'll come back a year later. But yeah, things happened, life happened. And yeah, so my husband had to jump through all the hoops of an IMG, an international medical graduate, because his training wasn't recognized here. And then at first we didn't know we were going to stay this long. So we first added another couple of months and then another year and then another visa. And then I thought, am I going to do? Am I going to pursue my medical registration here and jump through all the IMG hoops as well? And then I thought there must be other ways where I can use my knowledge and my experience and my skills. And that's how I got into coaching.
There we go. So tell us, what was your background? What was your medical degree for?
So I trained as a psychiatrist in the Netherlands. And when you train there as a psychiatrist, you also train as a psychotherapist. That was my specialty. I originally wanted to train as an immunologist. I
Yeah.
thought I was fascinated by the immune system, but then I did an internship in psychiatry, and I thought, oh, is this psychiatry? It's to me, it seemed like the most comprehensive way to help people just improve their quality of life. Yeah, that's what I pursued, and I worked as a psychiatrist for a couple of years in Amsterdam, for a while in old age psychiatry, and then I worked in medically unexplained symptoms, which was very fascinating area as well. Yeah, I really enjoyed that. And that is where I came across mindfulness. We
Mhm.
started using mindfulness in the early 2000s back in the Netherlands, also as part of ACT, acceptance and commitment therapy. And it was really fascinating because I was born with a bleeding disorder. And by that time, I was actually more or less chronic pain patient myself. And I was working with a lot of chronic pain patients. And I was really fascinated to see the difference, how I was sitting on one side of the table, actually
Mhm.
being quite content with my life
Mhm.
and feeling happy, content. And on the other side of the table were my patients who were suffering so much from their pain symptoms that they actually developed psychiatric comorbidity. And if you would look at the symptoms objectively, mine might be far worse. My walking pattern might have been much more impacted,
Mhm.
but it was really this mindset. And it was beautiful when we started with the mindfulness techniques. Then I realized this was actually something I had learned from a very early age,
Mhm.
having to monitor my body and the symptoms and having to act on it. And here I finally had practical strategies that I could teach my patients how to be more in control of what they put their attention on, and whether that was on the positives in life or the negatives. Because I was always considered a very positive person, even by my closest friends who knew that life wasn't always that easy for me. And so that mindset and how to help yourself focus your mindset and be more positive, that was something that really caught my attention then. And when I moved to Australia, it was actually one of the first things when I decided I wanted to work as a coach. I thought, what am I going to focus on as a coach? And I developed a program for busy professionals, how to use mindfulness skills to not burn out. And this was in the period before everyone was talking about mindfulness and the coloring in books and everything. And I thought that would be my added thing that I could bring, because nobody was talking about what stress does to the body. But I knew that this was what all the GPs were talking about with their patients, other doctors as well. So that's what I added to my program. And yeah, that came quite successful quite quickly.
Yeah. Was that referrals from doctors to you? Were you advertising yourself individually? How did that work for
I
building
actually
the...
started with a small group in the basement of my house because I'd never done something like that. I don't know about you, but in the Netherlands, we definitely don't get any business training during our medical school. So I was a complete unknown about how to do these. So what I just first did is when I developed the program, I invited some trusted people that I knew. And I said, I'm going to do these workshops with you. Please give me feedback.
Mhm.
And they did. So it went from there. Then it actually was just word of mouth.
Mhm.
And in no time, the Australian Medical Association Queensland, the AMAQ, they heard about me and then they asked me to develop a well-being program for junior doctors. So one thing very quickly led to another.
So I'm really interested to hear about this program in Queensland for the junior doctors because it was a lot of doctors, right? A
It
big number.
was, yes. I think in the end we had more than 4,500 going through the program. Yes, it was really exciting. So it started with a report that came out by Beyond Blue in 2013 here in Australia. And it showed absolute shocking numbers of mental health problems in both medical students and doctors. And unfortunately, that wasn't a big surprise. I think that happened worldwide. It's still happening today. The Council of Doctors in Training of the AMAQ, they said everyone is talking about burnout, but I think we need to do something about it. So they actually advocated for a program for junior doctors because we also knew that the transition periods, so from being a medical student to becoming a doctor, an intern, that was one of the most stressful periods. They said we want to have a program in place for junior doctors, for interns. And so when we developed it, it was first called Resilience on the Run, which
Mhm.
back then was still a positive word. In the meantime, it had gotten a very negative connotation about a lot of doctors feel that it's victim blaming. It's all about making you work harder in a very toxic environment, which of course wasn't what the program was about at all. We later on changed it to well-being at work, and that actually covered the content much better. Yeah, so first resilience on the run, then well-being at work. And so we started with a pilot up here in Queensland, and we did a pilot and we measured the effects as well. We got that published. And Queensland Health became very interested in this, and they actually came aboard and they supported it. So for about 6 years, I traveled through the state of Queensland. I went to all the teaching hospitals in Queensland to present the program. These were
Mhm.
2 workshops of each 1.5 hours during protected teaching time, during lunchtime.
Mhm.
And so I really got to work with groups of interns. We had a maximum of 30, so some hospitals had so many interns that I came for a couple of times. And yeah, so that was yeah, I loved doing it. It was a great program. We even got awarded Best Public Health Initiative. So it was, yeah, something that was recognized as successful. And then COVID hit. And so we changed the program to an online format, which worked. And then afterwards, when the program was up for renewal of the contract, They actually decided, Queensland Health, that it was better to have an online program so doctors could do this by themselves outside of business hours, which
Hmm.
I personally think defeats the purpose of a program, because one of the more consistent feedback that I got from the program was how important it was for interns to actually hear that they weren't going through all these experiences by themselves, but to actually hear that their colleagues were going through similar struggles.
Hmm.
And it was really important to create that awareness about what is happening to you. Why are certain situations within the workplace so hard for you? And like I said, you're not alone, and others are in it as well. So that was a very powerful part of the program that
Hmm.
was taken out. And but it freed up my time to, I actually started working more individually as well with individual coaching, because before I was so busy with the group
Hmm.
process. And yeah, and I noticed I really enjoyed working with the one-on-one again. And after COVID, so much more was possible online as well.
Yeah.
So I now do online coaching, mostly with doctors and
Hmm.
other professionals in high pressure environments. But I get to work with people in Australia, New Zealand, even overseas in the Netherlands, sometimes even in America. So yeah, it's really great to be able to work with a far larger group now as well.
Love it. What were some of the, within your workshops that you did, what were some of the principles that you were teaching the junior doctors that was so very helpful and valuable to them to change their, where they were to where they got to at the end, that measured response?
Yeah, I think, like I said, firstly, what we consistently heard was how important it was that they're not alone. I'm not alone,
Hmm.
because a lot of doctors feel very isolated, especially when they're struggling, and we find it quite hard to reach out and ask for help. And I'm no different. I know what that's like. And that was a very powerful message to get interns talking about this and creating that awareness. What does the stress actually do to your body? What are the aspects that are most stressful for you? Because every person is different. So we got to speak a lot about compassion fatigue, what it is, how it
Hmm.
is actually a normal psychological process to protect yourself against everything that you're confronted with, but to not be ashamed about it, but to actually speak about it with your colleagues. Of course, about self-care measures, but not so much the whole list of what we need to do to take care of ourselves, because every doctor knows that by now, and they talk about it with their patients. But
Hmm.
what is really interesting is what is keeping us from actually implementing that for ourselves. So, what are those both internal blockages that we make for ourselves, or systemic barriers that keep us from implementing this? So that is what we would talk about and generate far more awareness within yourselves, because a lot of doctors, they're so busy that they're just in their heads the whole time, and they don't even realize, for example, that they didn't drink enough. Why most of us, I would ask every group that I work with, I still do, every group of doctors that I work with, I say, we know that sleep deprivation is the best way to get people psychotic. It's used as torture. And then I say, but who in here actually sleeps enough? And I can
Hmm.
tell you that usually it's about 10% of the
Hmm.
group that I work with. And usually for the juniors, it's harder than for seniors. So
Hmm.
senior doctors often are a bit more of control of their lives, and they tend to be able to prioritize sleep a bit more. But we know it's a problem. And then when you have night shifts, or then start having young family, you have young children, it's extremely hard, even though we
Hmm.
know that it's one of the most important aspects to pay attention to. So the very basics, I always bring out Maslach's pyramid to really
Hmm.
show we all aim for the top tier of the blue, but there's so many layers before that we actually have to take care of. And we notice how I often heard how doctors don't feel heard, They don't feel seen. They don't feel safe in hospital environments. They don't feel connected. And really, by connecting people together, it can help with all these different layers because we can help each other with this. We can be the one to say to the other, okay, you go and have your lunch first, and I will take the next shift. Just the little things that we can do together. So those were things that we could talk about, also very practical strategies. What are people doing? What are tips that people can hear from each other that can help, practical tips? So compassion fatigue, burnout, we will talk about burnout as well, of course, how to recognize it. I find that burnout is usually far more about personal risk factors. Perfectionism is a huge risk factor for burnout. How contagious it is when you have one burned out colleague in your team. It can be extremely hard to keep engaged, and it really is that one sour grape. It can uh, take out the juice of the whole team. How hard that is. And over the years, I have actually added moral distress and moral injury to the program as well, because that is something that has come out more and more how I find that it's often mistaken for burnout, but when you explain what moral distress is, the frustration that you feel when you're not able to be the kind of doctor you want to be, that you feel is needed because of aspects that are outside of your control,
Yep.
often systemic issues, that frustration, that is awful. And as soon as you explain this, you can hear this sigh going through every group of doctors like, that's it. That
Mm,
is what upsets me most. And a
mm,
lot of us, I think we call it burnout, but it's actually that moral distress. And it's important to distinguish between the two because
mhm.
the drivers are so different and the way you need to address it are very different as well.
Yeah, yeah. I know that as a student doctor and as a junior doctor, because you really don't have a voice with what's about to happen for this patient, and you're seeing behaviors that have been in place for decades by these older doctors. You do patients who have procedures where they're not adequately anesthetized, or you have adverse events happen. Maybe you're part of the adverse event. Maybe you did something that wasn't quite correct because you're brand new and you've got supervisors, but you're really working alone for a lot of hours. There can
Mm,
be so many areas that we can be harmed in the process of becoming a doctor and those first few years of being a doctor. So I think this is incredibly valuable to have that highlighted
mm.
and some strategies for how to reconcile that within yourself and what to do about it in order to not let it keep poisoning you.
Yes, because you need to address this, because otherwise you have this reservoir within you of this frustration and it just keeps building. So you need to release some of that, and it can be extremely hard. But recognizing it is step one, because if you don't know what's happening, it's like with awareness with of everything. If you don't know what's happening, there's no way you can do anything about it. So it's very much, and that is why often when I discuss this also in my public speaking, when I explain the difference, I very often have people come to me afterwards say, thank you so much for mentioning this, because now I finally have the language, I
Mm,
finally have the words for it. And that is the start. That is what you need to start addressing first. And then it's very much about going back to your core values. What is it? What brought you into medicine? What is the most important part for you? What do you think makes a good doctor? And to recognize where wasn't I able to put this into practice. I remember
mhm,
for a while I was working with refugees back in Amsterdam, and I found it extremely hard to be treating their depression, for example, when I knew that 98% of the stressors were outside of my control. And I was thinking, what am I doing treating this depression here, where it's all about all these other stressors that they're going through money, visa, deportation, risk, all those things. And I felt awful at the end of the day. I felt awful about their situation. I felt awful that I couldn't be doing anything. And it was, yeah, almost as if you were there in name, but you
Mm,
weren't there, you weren't really there. I very much re recognize this, but it can happen on a daily basis. You want to refer a patient, and the waiting lists are extremely long.
yep.
It's the little things, and they just build up. And it's important to talk about each other and about this with each other, and to know that very much this is not something you can do with yourself. This is where we need to come together and advocate together. And it's extremely hard because the system is huge. We always talk about the system. We are part of the system as well. And
Mhm.
it really starts with coming together and to recognize little steps that maybe you can do.
Yeah.
And very much focus on not all the things that you don't have any control over, because that can give you a very hopeless feeling, but really focus back on, okay, what am I in control of? My own thoughts, my own actions. And by refocusing on those, you regain some sense of agency, and that makes a huge difference.
Yeah. I love that. So connection, like you said, connection in the workshops was such a valuable piece of it because coming together and hearing other people's voices and realizing you're not alone. We know that is so much a part of how we heal in medicine and how we avoid or improve on our burnout scores, our well-being, and even our moral injury. What did you see come out of those workshops? Was there any ongoing connection with the interns? Was that encouraged? Was there other hospitals putting in place other wellness mentors or programs? Did you see anything else in addition to what you were doing?
I really noticed when I started back in 2015, there was hardly anyone talking about well-being. And so it was a new topic. And then towards a couple of years later, about 4 or 5 years later, I would sometimes come into a workshop. I could see these rolling eyes going, oh no, not well-being again. People felt, oh, it's one of those fad words. And I have to say, I find that one of the hardest things about my current work is that there are so many of those fad words.
Mm,
They're just thrown around. And what do they actually mean? And yeah, I really notice a difference now, of course, 26. So it's about 10, 11 years afterwards. There is a lot more focus on well-being, and being able to go to all those different teaching hospitals, you could really notice the difference in culture in the different hospitals as well. Some hospitals would take care of their interns by providing them lunch, for example, take their pagers during
mm,
protected teaching time. I think that is a big thing as well, because sometimes I would be there and I would have a whole group of interns, and their pagers would be going off all the time. This is protected teaching time, and
mm,
there's not much protection for them. So some medical education units would be really fierce at protecting that, which
mm,
was great to see. And in other hospitals, that just wasn't possible for them. But over the years, you can really tell that the impact on the culture,
mhm.
understanding how important it is to focus on well-being for interns as well, I think that has definitely increased.
Yeah, fascinating, isn't it? Just that one thing of calling it protected teaching time, but leaving them with their pager. If you
Mm,
had said to me as a junior doctor, you get protected teaching time and your resident has to take your pager from you for that hour, I would have been more delighted to go to that teaching session.
yes,
Just
yes,
to have an
exactly.
hour
Other,
break from that stupid blinking pager.
yes, yeah, yeah, no, exactly. It's you can't have both things at the same time and have the protected time and still be at work.
What about the safety to share their stories with each other? What do you do to help facilitate that?
Thank you for asking that question, because that is a very important part. I think over the years, that is the thing that I learned the most, how to engage everyone in the room. Also, the people sitting in the back row, scrolling on their phones, thinking, yeah, well-being, it's not my problem. And so there's two things. One of the first, so at first, when we started with the program, it was open, and
Mm-hmm.
also, and because it was new, we sometimes would have other disciplines that would like to
Mm-hmm.
come and sit in because, yeah, it's an important topic. And the feedback we got was how unsafe that felt for the
Mm-hmm.
interns to share their insecurities
Mm-hmm.
and mostly situations that they felt insecure about and show that vulnerability. So then we started to just have it for the interns and for medical doctors, which got a bit of pushback from the hospitals because it was seen as maybe a bit of that elitism that sometimes is seen in doctors, but that was very much not what it was about. It really was about being able to be more vulnerable
Mm-hmm.
and feel safe enough to do that. So we really tried to explain that was why this was put into place. And I also invited more senior doctors, especially the leadership, so the directors of clinical training, but sometimes even higher up. I would really welcome them into the workshops, and I would ask them beforehand, do you mind if I ask you questions to share your experiences? And if that would happen, something really magical happens because I would share my own experiences as more of a role model. And I
Mm-hmm.
really noticed that role modeling, how important that was to let the interns know this is normal. It's normal
Mm-hmm.
to struggle, but to actually have the leadership, the medical leadership of their own hospital share their experiences with failure, with insecurities, with moments that they were struggling. That was so powerful. So I really try to get that more going because that is something that creates a real difference. Once that has happened, you can't undo it anymore. And interns feel much more at ease to share amongst themselves, but also with their director of clinical training, for example, their medical education unit.
Yeah. Do you feel like having those leaders there as interns voiced their worries and concerns, they may have felt more heard?
Yes, I think so. I think if you're in the room and you hear it directly, you can't unhear it. It's different from hearing it through different layers. Somebody is voicing something that an intern has said, but there's three layers between you and the intern. It's far more distant than when you hear it one on one.
Was there an opportunity for you to be able to feed back to the hospital what the interns were saying? Was that part of what your role was?
Not officially,
Mm.
but if there were certain systemic issues that would come about. So I did allow the medical education unit to be there because they were the trust people of the interns.
Hmm.
And I would ask for them to be there because they would know more about specific stressors of a hospital, for example. And
Hmm.
then the feedback would go directly to them and they could do something about it. And sometimes there might have been certain things that came out of the workshop where I thought that would be really good if the medical education or the director of clinical training maybe would put some more emphasis on. And I would get back to them about this. Yeah. But that would be my observation.
Yeah, fascinating because it's also then providing some advocacy for the junior doctors from
Mm.
a professional perspective of that interpretation of this is what the interns are saying, but I, from the professional point of view, can see this interpretation of that to help them
Yeah,
as
yeah,
a strong piece as well.
yeah,
All right. Yeah. How do people get in contact with you if they're interested in either connecting one-on-one or learning more about the program that you offer?
yeah. I think the best way is to connect with me through LinkedIn. I'm not very big on social media, but LinkedIn is my preferred channel. And I have a website. So my current business is called Vitae Wellbeing Leadership. And so both vitawellbeingleadership.com and vitaewl.com. is how people can reach me through my website as well.
Perfect. Is there anything we didn't talk about that we should talk about before we end?
Oh, there's so much more to talk about. I do. One of the other things that I've really noticed over the years is how important it is for doctors to realize that the same aspects that make them a great doctor, so be very caring, perfectionism, diligent, are also often the factors that contribute to having low levels of self-compassion. And
Mm,
I wish that all the research that has come out in the past 15, 20 years, I wish we would have had that 30 years or more earlier, because I find that this is one of the main problems that many doctors have. And I think we select these really kind, wonderful people, and then we train them to be doctors, and then they come into a system where it's like a perfect storm, because the
mm,
hierarchy that they then enter in, together with these low levels of self-compassion, with this critical inner voice being really harsh on themselves, and it crushes them.
mm.
And thinking back, I think a lot of the people I had in psychotherapy, they were suffering from low levels of self-compassion. And had I had the tools that we have now to focus more on that, I think I would have been much more effective then. And I think it's really important now as well for people to know that they should treat themselves, or at least ask themselves the question, what would a good friend tell me at this moment? And believe that good friend more than believe that critical inner voice that is sometimes sabotaging them. I think that is a very important thing.
I think you're so right. But having had a lifetime of that, putting yourself, how do you say it, the having lower self-compassion, it's going to be difficult to suddenly change that thinking in your head.
Yeah, no, and it doesn't happen overnight. It's what I work with a lot of my doctors in the individual coaching as well. It's often going back to your core values. What is really important to me? What can I control? And becoming aware of that critical inner voice when it's happening again, and when it creates to self-limiting beliefs. A lot of these brilliant minds, brilliant people, lovely people, they feel like they are an imposter in the places that they are, or they're not good enough. And it's that self-sabotaging that is keeping them from leading a life which is much more fulfilling and happier. Yes, that is often you can't do it alone. And coaching can really help in this respect.
I think that's so important that it doesn't need to necessarily be medicalized, but there is structure and professionals who can help you overcome decades of this limited self-compassion, that inner voice that is demanding of you and creating this cycle, like you said,
Yeah.
of perfectionism and diligence and compassion, but not towards yourself.
Yeah, and when you look at the hidden curriculum that we have in medicine, how you have to self-sacrifice and not speak up and not complain and just toughen up and go on. It's often something that is very much internalized. Sometimes we grow up with parents that this is their strategy of to bring us up. So it's ingrained. It's like an automatic reaction. And it will take some time to change that. And the first step is to actually become aware of it, take a step back and look at it for what it is rather than have it internalized completely. And you can't do that all alone. And coaching can help because that is where you get asked certain questions and you go, oh, I never thought about it that way. So it really is about getting a different perspective. Yeah. And like you say, it's not medicalized. It's top athletes are allowed to have coaches. So why aren't doctors allowed to have it?
Yeah, yeah. Do you think this is somewhat part of the, do you think there's some gender ties with this? Just when I heard you speaking about the parts about self-compassion, I just wonder if women physicians are more vulnerable when you're talking about that perfectionism and lack of ability to self-compassion, have you noticed any significant differences in gender when you've been doing the workshops or having a look at the physician well-being?
I do think that this is very much the case with caring men as well. And I
Mhm.
do think, like I said, there is a selection at the door for the medical school, but there's also, I think, a self-selection. People
Mhm.
that care are more likely to be wanting to work in healthcare, in caring professions. I also do a lot of work with the Queensland Medical Women's Society,
Mhm.
and there I often see that this is something that women are definitely suffering from. I think the socialization is also that women need to be nice and kind and not speak up, whereas men are often taught from a younger age that they are more allowed to speak up, and that critical inner voice is more, I think, is more cultivated in women's socialization than in men. There's a lot of research that talks about this as well. But in my workshops, I definitely
Mhm.
also see it in men.
Yeah, and when I work with all genders in my program, I do see that you're right, the self-selection into medicine or the people we're choosing to put into our medical programs are our highly compassionate, dedicated, highly perfectionist or attentive to detail kind of folk. And so you're right,
Yeah,
it's not going to just be the women. In medicine, we're going to see that across all genders.
yeah, yeah,
But I just, when I heard that, I'm like, interesting that you've linked that type of personality to the outcomes of higher risk of burnout and compassion fatigue and not doing well in the structure and systems that aren't set up for doctors and
yeah,
clinicians, where that ability to be harmed by the system because we can't do medicine, practice medicine in the way that we would prefer.
yeah, exactly. Yeah, yeah.
Yeah. Interesting conversation. Thank you, Era, for this. All right. So, if people are wanting to reach out to you, we've given you your details. Any other words of wisdom before we close?
I think I would like to add how important it is to also focus on those aspects of who you are outside of medicine. So to not only have that identity of being a doctor, especially as a junior, you work so hard
Mm.
towards being in that role and you spend so many hours, but there's more to you than just being the doctor. And don't forget that, and also focus on those aspects because, especially later on, it will become more and more important to know that there's more to life than just medicine.
Oh, yeah, so true. I love that. That's a great way to end. Thank you so much for this conversation.
Okay, thank you very much.
And you guys have a wonderful rest of your week. Bye for now. Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.